Good morning. We're going to get started. Thank you, everyone, for coming this morning. It is my real pleasure to introduce Al Matsumoto, one of the many world-class researchers we have here at the University of Washington. Al is an endocrinologist. He told me to read what's on his slide because on his CV, the number of things that he's responsible and in charge of goes on and on. So I'll just say that he is the director for the clinical research unit at the VA. He's a professor in the Department of Medicine and Endocrinology, and he's at the gerontology section at the VA. One thing I do just want to highlight that I saw on your CV is just the unbelievably large number of fellows and trainees that you have mentored over the years. And I believe you are the head of the Gerontology Fellowship. Nope, not anymore.
Nope, not anymore.
Too
old for that.
What he is one of the world's leading experts on testosterone, and in particular testosterone and its effect on cardiovascular disease, as well as a clinical trialist in this area. He has had some really exciting recent work that's been widely published both in the academic and popular press, there was just no way that we couldn't have him come and join us and educate us about this hormone that impacts a lot of what we do, but I don't know about you, I don't think about it very much. So it is a real pleasure to have you here, Al. Thanks.
Thank you. Oops, sorry. Erica, is this on?
Yeah, it should be on.
Is on? Okay. Can you hear me back there? Okay. Thank you very much for the invitation to speak, particularly about testosterone, which has been my 30-year career here, revolving around testosterone. My disclosures are here. The two most important disclosures, I think, are the fact that I actually was on the Endocrine Society task force that just put out the revised third revision of the guidelines for testosterone treatment in men with hypogonadism in March. And the last disclosure, I think, is the most important. I'm not a cardiologist, but I consider myself an endocrinologist as well as a geriatrician. And so I'm going to come at this particular topic from that standpoint, and not from the standpoint or the perspective of a cardiologist. And so I'm a little bit out on a limb here. So excuse me if I use the wrong terminology for the cardiovascular issues or the cardiovascular disease. It's just a lowly endocrinologist here. I think the objectives are here. It's basically when you're presented with an individual, let's say in cardiology clinic, that has some type of cardiovascular disease, but that's on testosterone treatment, you have to ask yourself, who's an appropriate candidate for actually receiving testosterone treatment? And maybe not so much you all, but should be aware of how to monitor and how to manage individuals if you see something that's a little unusual or something that's a little off base from what you think should be going on. And in this day and age, we're just talking about testosterone clinics and so forth. I think there's quite a bit of the potential for not treating individuals correctly or not monitoring them carefully enough. So what's the problem? Spend a little time on the problem. I think one major problem here is that hypogonadism, which is really the only indication for testosterone treatment, is overdiagnosed and overtreated. And there's a large number of reasons for that. I think one of the main reasons is that there are a lot of people now that are keying in on symptoms and signs of testosterone deficiency and using that as the only criteria for diagnosing somebody that needs testosterone treatment. Also, there are individuals that get testosterone levels drawn for no good reason, for no clinical indication, that are actually finding individuals that have a slightly low testosterone level and therefore using that as a criteria for treatment with testosterone. And so those two things, I think, are the major reason overdiagnosis and overtreatment occurs. More recently, I've tried to point out that endocrinologists, cardiologists, anybody in subspecialty internal medicine should think a little more broadly and more like a generalist and really think about the fact that if you have symptoms and signs of androgen deficiency, which are totally nonspecific, they could be due to something else, right? A lot of comorbidities out there in the populations that we see, particularly in the late middle age to older population, that could cause these symptoms and signs. And there's also reasons why testosterone may be low unrelated to hypogonadism. Okay, these individuals don't have hypogonadism, they may have low testosterone, and we'll talk a little bit about that. As well, I think people should realize that even in somebody with definite hypogonadism, low testosterone symptoms and signs of testosterone deficiency, some of their symptoms and signs could be treated without testosterone. Prime example is erectile dysfunction, which is a manifestation of hypogonadism, but that can be treated with PDE5 inhibitors, right? Sildenafil, Cialis, those types of medications, really kind of pointing to the fact that it's largely a vascular problem in the penis, not really as much a testosterone deficiency issue. So I think we have to keep that in mind. The other part of the problem is that as we get older, hypogonadism and cardiovascular disease are pretty common. They migrate together as you get older, and they also are associated with age-related comorbidities, as we'll talk about. And then also, both of those conditions, the risk of both of those conditions goes up with some very common conditions that we see all the time, like obesity and diabetes. And then finally, I hesitate to say this because, you're going to say, well, okay, no outcome studies, I better go home. There are no outcome studies for assessing cardiovascular risk of testosterone treatment. There is one that's starting up, and I'll mention that later on in the talk. So as we consider potential candidates, who would be the ideal potential candidate? Well, individuals with unequivocal hypogonadism. So what do I mean by that? Individuals that are very symptomatic, that have all the classic symptoms of hypogonadism or testosterone deficiency, including low libido, low sexual function and activity, particularly. They have very low testosterone levels, so unequivocally low, not just slightly below the lower limit of normal, but just, very, very low testosterone levels. They have no confounding symptoms that might be related to other causes or low testosterone for other reasons besides hypogonadism. And they have an organic cause. Now, what do I mean by that? An organic cause is a structural problem in the hypothalamic, pituitary, or testicular level of the axis. And those are things like pituitary tumors that destroy pituitary function, hypopituitarism, Klinefelter syndrome that damages that it's a congenital problem that causes testosterone deficiency primarily in the testis. Those are the ideal candidates. I'm going to spend a little time about how to diagnose hypogonadism. Believe me, I will get to the cardiology here soon, but I think it's important to frame this in the context of what I mean by hypogonadism. I think the Endocrine Society Task Force that's been putting out guidelines for this really from the beginning has emphasized the fact that in order to make a diagnosis of hypogonadism, you need both signs and symptoms of testosterone deficiency and consistently and repeatedly low testosterone levels. And the consistently and repeatedly, I think, is a very important concept here, and we'll get into why that is. So if symptoms and signs alone are used, or low testosterone levels alone are used as a criteria for diagnosis of hypogonadism and therefore to justify treatment with testosterone, I think you get into trouble. It's emphasized by this complicated slide. Excuse me for this complicated slide, but let me lead you through it. This is the prevalence of low testosterone alone in the gray bars from the cohort, the Baltimore Longitudinal Study of Aging, and 3 other cohorts that included low testosterone with some complex of symptoms. And what you see here is, if you key in on the gray bars, that if you use testosterone alone, low testosterone alone as a criteria for diagnosing hypogonadism, you're going to be diagnosing hypogonadism in older individuals quite frequently. In fact, this is in community-dwelling, relatively healthy individuals. You throw a few comorbidities in there as you get older, and just about everybody will have a low testosterone at one point or another. And so I think using just the biochemical diagnosis is not appropriate. As opposed to when you see the colored bars here for the other cohorts using a variety of symptoms of multiple symptoms or just sexual symptoms, the actual prevalence is much lower. It still goes up with age, and the actual, oops, sorry about that. The actual prevalence here is really more close to 2, overall prevalence is more close to 2 to 8%, and more, some in the range of 5 to 6% probably is a good average. So how do we get into the situation of overdiagnosis and overtreatment? Shown here are basically trends in testosterone testing and treatment in the US versus the United Kingdom. And the testing is in the left-hand side here, and the initiation of treatment is in the right-hand side. And you'll see from 2000 to 2010, you'll see that in the US there's been a dramatic increase in testing. So with the testing, you wonder about, with the low testosterone levels that are going to be found when you test more, are more people going to be diagnosed? Is there going to be overdiagnosis? And shown here in terms of the prevalence of increased initiation of treatment, the question is there overtreatment as a result of overtesting and overdiagnosis? And I would submit that the answer is yes. And I don't think you have to go too far to actually find overtreatment and overdiagnosis. We have a lot of reasons for why this has occurred. One of the main reasons is that there's now since 2000, there's been a relatively convenient transdermal approach to treat individuals with testosterone. And direct-to-consumer advertising has occurred. So I'm sure you've all seen advertisements for low T, the low T syndrome. That isn't really a diagnosis, but it's being really a marketing tool to actually market the testosterone treatment. As a result of that, you see Time magazine and a lot of media really playing on the fact that as you get older, your testosterone levels go down. Maybe you have menopause. You have something that's equivalent to menopause. And then finally, there's a lot of testosterone clinics, not only here, but as Robert were talking about before in Southern California, but all around the United States. In contrast to the UK, there's not quite as many. There are a few there, by the way. But that aside, it's really been a large number that have blossomed in the United States that are using the biochemical test primarily to diagnose hypogonadism. So, moving to other causes. Again, putting on a more general internal medicine hat, you have to recognize that the symptoms and signs of androgen deficiency, testosterone deficiency, are really nonspecific. And so listed there are a bunch of potential causes of some of the same kinds of symptoms you would have for testosterone deficiency. And listed among those are some conditions that are cardiovascular risk factors. Obesity, CKD, they can cause fatigue, low energy, low libido, erectile dysfunction, those kinds of things can occur. So you can see that if you're not thinking outside, of just the hormone, and this is a problem with endocrinologists particularly that concentrate on low testosterone, we have to kind of treat that hormone deficiency. I think if you think more broadly, you'll come to find out that maybe sometimes some of the symptoms are more appropriately attributed to some of these other conditions and may be treated without testosterone. Oops. Sorry about that. Okay. Somehow I'm off. How did I do that?
Can you just...
I can't. Let me go out and come back in.
Okay.
There's always a glitch. Okay. So what are some of the other causes of low testosterone that you have to be worried about that really is not related to hypogonadism? I think one thing that you might see in cardiology clinic, may or may not, is that somebody that's acutely ill, that's in the CCU or in the ICU for that matter, or even in the hospital, during that time their testosterone levels are going to be low. I'm sure no one measures testosterone, hopefully, in the hospital, but for a short period of time, or sometimes a long period of time after they get out of the hospital, testosterone levels can be very low for quite some time, for months. This is well demonstrated by Dan Spratt and others many years ago. So you have to consider what happened before you measured the blood test. Did they get a burst for COPD exacerbation, for example, that can lower testosterone to almost castrate levels acutely, but then takes a while for it to come back. And with the taper, even though you're tapering the dose of prednisone, testosterone levels can be low. So transient low testosterone is common. Biological variability is exceedingly common. So a lot of things that we learned from the pivotal trials of testosterone, transdermal testosterone initially, using a single testosterone level as the criteria for entry into studies. What happened is that they qualified on a low testosterone on a single value. They come to the baseline visit where they actually start the study, and lo and behold, 35% of those individuals will have normal testosterone at baseline. So the variability there is quite great, to the point where anybody that has a slightly low testosterone level, obviously if you're castrate levels, it's probably not going to go back up to normal, but anybody just slightly low or even definitely low can have testosterone levels on a second blood test that's actually normal. Not a good situation. We also know that there's a circadian variation in testosterone, so if you measure testosterone levels in the afternoon or in the evening, they're lower than in the morning when all the normal ranges are established, by the way. So that, you could get a false impression of a low testosterone just because of the time of the day. Also, we know more recently from Francis Hayes and others that testosterone can be suppressed by glucose intake or food intake. And so fasting is much preferred. And then finally, the last bullet there is, and I won't get into this because it's quite complicated, but there is a condition where binding protein of androgens or testosterone can be low. And the main reason for that is obesity. And it could be moderate or mild obesity that causes a low SHBG, low total testosterone, but the free fraction, the fraction that's biologically active at tissues, in fact, is normal. So, and these individuals are not hypogonadal, even though their total testosterone level is low, their free testosterone is normal. Okay. So just to emphasize that, testosterone levels bounce around a lot, I want to re-emphasize the fact that, in fact, 30% of the time, that variability can get you into trouble if the initial testosterone is low. And so that's the rationale for repeating AM fasting levels to confirm low testosterone levels. And this is important for anybody that's going to do studies carrying forward. In a recent meta-analysis that we did as a part of the guidelines, we tried to find all the studies that actually use the criteria of having at least 2 low testosterone levels as the biochemical criteria in the morning fasting as the biochemical criteria for the diagnosis of hypogonadism, and there was one study that did that, and I'll talk to you about that one. That was the testosterone trials that I participated in. So all of the other studies have not used this rigid criteria for the diagnosis. Example of sort of what the variability in testosterone levels are. So here is the same sample. So a blood sample gotten from a hypogonadal man with low testosterone levels, symptoms and signs and all that, that was sent around to over 1,000 labs. And they were asked to measure testosterone in their assay. And you can see here in the very top line of all those 1,000 labs or 1,100 labs, the range of values in the same sample was almost tenfold different. Now, come on. This is not, this is unacceptable, right? And I'm going to tell you, even though it's not quite as bad for other analytes using the more modern automated platforms, if you're talking about troponin, if you're talking about any type of immunoassay that's a platform assay, you have to be aware that the variability, the assay-to-assay variability, is quite great in a lot of those unless they're standardized. That's the problem. There's no standardization of testosterone levels, so different assays will read different values and different normal ranges will exist. So I'm sure you've seen this in the community versus the university, or the VA versus the UW. Labs have different ranges and they have different assays and they have different accuracies. And the problem is that there's no standardization. And so I've been part of a group called PATH, the Partnership for the Accurate Testing of Hormones. It's working with the CDC to basically try to standardize and harmonize testosterone assays throughout, at least throughout the United States, hopefully throughout the world, but throughout the United States. And the rationale is this unacceptable variability in the measurements that we're getting. Okay. And actually, we've done quite well with reference labs, and that all the reference labs have now been certified as being accurate, and they're harmonized within 6%. So their values range 6% plus or minus 6%, which is pretty good for testosterone assays. We've established a harmonized reference range with over 9,000 individuals from various cohorts internationally to have one reference range. That is an ongoing effort. I think that's something that will help avoid individuals being overdiagnosed. So, moving on to hypogonadism. Somebody has hypogonadism. I think you have to recognize that not all hypogonadism is irreversible, and that is in large part as a function of the two major epidemics that are going on here, the opioid epidemic and the obesity epidemic. Both opioids and obesity can lower testosterone and actually can cause hypogonadism. Is there a fire? No, sorry. Okay. So what's the difference between organic and functional hypogonadism? Organic, as I said, is structural problem, unequivocal hypogonadism, very low testosterone, very symptomatic, mostly a problem in the testis, but can occur in the hypothalamic and pituitary axis. Functional hypogonadism is a term I use that's equivalent to what many of you are familiar with as functional amenorrhea, that is exercise-induced amenorrhea or ballerina-induced amenorrhea, anorexia-induced amenorrhea. Those kinds of things, external environmental conditions can actually affect periods, menstrual periods, but they can also affect testosterone levels by suppressing the pituitary hormones that regulate the testis. And so when you think about the causes of secondary hypogonadism, the causes can be organic, they can be actually tumors of the pituitary that destroy the function of the pituitary, lower LH and FSH and lower testosterone. But really the functional causes highlighted here, particularly in the population that you all probably see and that I always see at the VA, really come to fore and are the most prominent causes of hypogonadism in this day and age. So it's no longer Klinefelter syndrome, it's no longer hypopituitarism, it's all these functional reasons to have hypogonadism. And the reason to mention that is that they can be treated independently of testosterone. They can, for example, obesity as a sort of a Venn diagram to cardiology, and hypogonadism can be treated with weight loss, exercise, which will do both conditions good and will be good for general health. I think I use this as sort of a motivation for obese individuals with low testosterone that might actually even be hypogonadal, let's see if we can lose some weight. And as a motivating factor for either obesity and sometimes for opioid use, it's pretty good to actually it works pretty well, in my experience, if you spend some time on this, to actually get them to lose weight. And as a result, testosterone levels come up and presumably heart disease risk will improve. And then finally, treating hypogonadism symptoms and signs with other things besides testosterone. I mentioned PDE5 inhibitors for erectile dysfunction, but again, exercise, weight loss. Bisphosphonates for osteoporosis is a manifestation of hypogonadism, but can easily be treated, not easily, can be treated with bisphosphonates, and has been demonstrated to work in hypogonadal individuals that aren't treated with testosterone. So you don't need testosterone to treat some of the manifestations of hypogonadism. So I'm going to have to show you this slide, again, just to emphasize that in addition to hypogonadism increasing with age, we have cardiovascular disease increasing with age, both in men and women. And I won't spend too much time on this because, you know, in thinking about getting ready for this talk, you know, I went through my mind as to what are the cardiovascular effects of testosterone, and they're exceedingly complicated. And I'm going to just highlight a few things. So if you're ever going to do studies with sex hormones, and testosterone in particular, you have to remember that testosterone in the body is converted to estradiol or dihydrotestosterone, DHT. Estradiol is an estrogen. So when you give testosterone, or when you're thinking about endogenous testosterone floating in the blood, it's converted to estradiol. So not only do you have an androgen effect, but you also have an estrogen effect with testosterone treatment. At the same time, you also have a much more potent androgen. DHT is tenfold more potent than testosterone and as an androgen. And until recently, we couldn't measure this very well. We could only measure it with these immunoassays. But in our lab and other labs now, the state of the art now is to measure steroids by mass spectrometry-based assays. And DHT is now measurable in blood, accurately measurable in blood. And lo and behold, a lot of the observational studies that we've done show a relationship to, for example, of DHT to stroke and those kinds of cardiovascular outcomes, as well as other outcomes. And so we're actually rediscovering DHT as an active metabolite of testosterone that might actually have impact, at least observationally, on cardiovascular disease. In terms of, you know, spending some little bit of time on this, atherosclerosis, there's pretty good evidence from observational studies that testosterone treatment lowers some of the risks of cardiovascular disease. And there's some evidence that in a non-genomic fashion. The other complicated feature is that steroid hormones act on steroid receptors, androgen receptors that are intracytoplasmic, go to the nucleus, intranuclear, and then act on genes to alter gene transcription. That's the classical mechanism of action. But lo and behold, nowadays we have steroid hormones acting non-genomically on cell surface, sometimes with androgen receptors on the cell surface, but also even without interacting with a receptor, and actually causing very rapid effects that are not genomically mediated, okay, so are not genetically mediated. So what happens is, there have been a couple of, and to my knowledge, only a couple of groups that have actually demonstrated if you infuse testosterone directly into the coronary arteries, you can actually have vasodilation. So that's an aside, because I'm not going to talk about that, but I'm just trying to highlight the complexity of these effects. We also have other effects on the cardiovascular system that I won't go into, like the QT and the risk of AFib and exercise performance and heart failure and ischemic heart disease. But one thing that I would like to highlight is that there's also an increased risk with testosterone treatment of erythrocytosis. That is, hematocrits and hemoglobins going up higher than they should be, which could play into cardiovascular risk. So when I grew up in reproductive endocrinology, the main concern with testosterone treatment was prostate cancer. Okay, and what happened around 2010 or so was the TOM trial was published. The results of the TOM trial, adverse effects of the TOM trial were published in the New England Journal of Medicine. And wouldn't you know that all of a sudden now, prostate cancer is no longer an issue as much as cardiovascular disease and testosterone treatment. So I'm going to spend a little bit of time on testosterone treatment as it relates to the TOM trial. The trial published in the New England Journal 2010 was a randomized trial of relatively frail individuals with mobility limitation that were randomized either to testosterone gel or placebo gel. But the testosterone gel and the dosage used was higher than even the recommended FDA package insert dosage of testosterone. So it went up to 15 grams daily. And they were adjusted so that the levels of testosterone would be on the high end of the normal range. The patients were at moderately high or modestly high cardiovascular risk because they had a whole host of cardiovascular risk factors, not uncommon for the age group that was studied. And even though they found improvements in muscle performance, in leg press and chest press strength, as well as stair climbing power, there was an increase in cardiac adverse events. These are self-reported AEs in a clinical trial. And the DSMB, the Data Safety and Monitoring Board, recommended early discontinuation because of the large number of cardiovascular AEs, 23 subjects in the T-treated group versus 5 in the placebo-treated group had cardiovascular AEs. So what were those? So I've categorized them in sort of order, and this is somewhat of a arbitrary categorization, but I put the more worrisome ones at the top here, and the less worrisome ones like a carotid bruit or chest pain, non-specific chest pain down below here. And what's highlighted here is that indeed there were more major adverse events, cardiovascular adverse events in the testosterone group compared to the placebo group. But we're talking about very small numbers here, guys. And could this be due to chance? Well, I think it certainly could be. There weren't a large number of individuals studied, but the amount of concern that was generated was clear after the trial was published. These types of adverse events seem to occur all throughout the 6-month period of treatment as well as into the 9-month recovery period. So the testosterone groups really did experience more self-reported adverse events. So what that generated was 2 sets, a reinvigoration of looking at the relationship between endogenous or circulating testosterone levels and cardiovascular events, and pharmaco-epidemiologic studies of testosterone treatment and cardiovascular events. Okay, so I'm going to talk about the epidemiology first, and instead of showing you a whole lot of forest plots here, I decided to just summarize the fact that there have been meta-analyses of the relationship between endogenous testosterone and cardiovascular events that have all basically been negative, except for one meta-analysis that showed that low testosterone levels were associated with increased cardiovascular events. Okay, so in fact, you would think, therefore, if this were true, maybe testosterone treatment might actually decrease it. We'll get into the pharmaco-epi studies. I think the problem with trying to interpret these is that there's a whole lot of heterogeneity in these, as well as on every meta-analysis. To tell you the truth, I'm sorry if there's some meta-analytical people in the audience, but every one that I've seen has really been, in this area, has been a little bit too heterogeneous to be useful for clinical practice. That's the bottom line. What about the pharmaco-epi studies? Well, what happened shortly after the publication of the TOM trial is there were 2 pharmaco-epidemiologic studies that demonstrated testosterone treatment was associated with increased cardiovascular events. That's the Vigan study and the Finkel study. They were the first ones to be published. And so that drove even more concern, and the FDA, in fact, after that period of time, even though they felt that there was problems with the study, those pharmaco-epi studies, they felt that there needed to be a warning that the testosterone treatment might actually cause cardiovascular problems or cardiovascular events. Subsequently, there are 6 or pharmacoepi studies that showed no association or actually even an improvement. And so the limitations for all of these are, I think, shown here are the limitations for all pharmacoepidemiologic studies. I think the major ones for the 2 that were initially published had to do with selection bias or indication bias and the fact that prescriptions were used as exposure, and for one study, misclassification of individuals that had treatment, actually did have treatment with testosterone, were classified as having no treatment just because of a day difference in the starting of the testosterone dose. So those kinds of things make these very difficult to interpret. And then finally, there's been meta-analyses of testosterone treatment trials. Now, all the testosterone treatment trials I've talked about have been really relatively small. And the one I'm going to talk about, the testosterone trials, as it's called, was the largest. But in reality, they've all been underpowered to actually look at cardiovascular events. So a lot of people use meta-analysis to try to improve the numbers. And suffice it to say, there's only been one meta-analysis that showed that testosterone treatment was associated with increased cardiovascular events. That's this particular article here. And I'll show you some of the data that's generated here in these other meta-analyses that all show basically no difference in cardiovascular events, but the ZEUS trial, basically, or the ZEUS trial, is the only one that shows an increase in cardiovascular events. And so here's the forest plot for that particular study. The problem is that if you look at the weighting of the studies, the Tom trial was heavily weighted. The Jones trial was heavily weighted. This is a group of very, very advanced diabetes patients. And the Copenhagen trial was heavily weighted. And that's the trial that I think you ought to be that really throws meta-analysis into question, because these individuals had far advanced alcoholic cirrhosis. All of the patients in that trial had alcoholic cirrhosis, and they used an oral preparation of testosterone that was unapproved for use, at least in the United States. And they caused a lot of comorbid complications. So again, as meta-analysis goes, do the studies in this meta-analysis speak to individuals that I would normally treat with testosterone? And if you look at just the highlighted kinds of patients that were actually studied in this, CKD on hemodialysis, come on. I mean, these guys are at high risk anyway, and the question is, would you be treating these individuals with testosterone anyway? And so the answer in my mind, is no. So I don't find those meta-analysis very useful for people in the clinic treating people. As I alluded to when we did the Endocrine Society guidelines, in fact, there were only 4 studies that came close to the definition of hypogonadism that I just talked about earlier in this talk. So again, there's not enough data to support any kind of evaluation of cardiovascular risk. The testosterone trials, I'll spend a little time on, is a study that was 20 years and occupied the vast majority of my investigational life, because a lot happened before the testosterone trials, and we won't get into that. It's a long story. I'll tell you that some other time. But eventually the testosterone trials did get funded, but it was funded not for an outcome study that I wanted to do 20 years ago, but as a short-term efficacy trial to determine whether or not testosterone treatment, particularly of older men above the age of 65, that's older, not old, okay, and that now I'm in that age group, so I'm sensitive to that had symptoms and signs of androgen deficiency, testosterone deficiency, that had unequivocally low testosterone levels, less than 275 on at least 2 occasions, and a low risk of prostate cancer. This was not just one trial. That's why it's called the testosterone trials. It was actually 7 coordinated trials. each trial embedded within the trial. With this main trial, there were three main outcome studies that dealt with sexual function, physical function, and vitality. And then there were also cognitive function trial, a bone trial, anemia trial, and one that you're probably most interested in, the cardiovascular trial. Well, I'll talk about those. The testosterone preparation that was used was testosterone gel, a transdermal preparation, starting out at 5 grams a day, but then it was adjusted over the course of the period of the study and very carefully adjusted so that testosterone levels were in the, excuse me, were in the mid-normal range. Excuse me. It took a while to recruit these individuals because over 50,000 individuals were screened in order to enroll 790 individuals. So it's a 1.5% enrollment rate. And overall, I think what's informative about the enrollment is that overall only the criteria of 2 testosterone levels that were low was present only on 14 or 15% of individuals. So again, if you use 2 testosterones as a criteria, you're going to really eliminate a large population of individuals that have a testosterone level that's low on one occasion. And I think that's a very useful thing to keep in mind. The 790 men enrolled, 95% completed, and there were no difference in the completers versus the non-completers, but there's an intention to treat analysis. The individuals in this trial were basically older individuals, average age 72 or so. They were obese, BMI of 31. They had they had their usual cardiovascular risk factors. There's nothing particularly unusual about the group in terms of the age group. They had a relatively low risk of prostate cancer based on the prostate cancer risk calculator, as well as having dysfunction either in physical function, gait speed, sexual function, or vitality using the FACIT fatigue questionnaire. Their testosterone levels compared to placebo increased right where we wanted, but again, we were adjusting for the testosterone levels to be within this range. And executive summary of the results, rather than going through all the results, showed the following, and I'll spend a little time on the cardiovascular sub-study after this. But the results were that, in fact, there was a moderate increase in sexual function, as you might expect, a small increase in mood and depressive symptoms, an increase in walking in all the men, but not just the men that were enrolled in the physical function trial, no change in cognitive function, an increase in bone mineral density, volumetric bone mineral density, and bone strength, and increase in hematocrit, or hemoglobin, both in anemic patients as well as non-anemic patients. The one that you're probably most interested in is that there was an increase in non-calcified coronary artery plaque, and we'll talk about that. There was an increase in hematocrit above or equal to 17.5, more in the testosterone group, but there were no increase in cardiovascular adverse events. And so, seeing here, there were some, but they were equally distributed between placebo and the testosterone group. But again, the number of events, small, the number of participants, small, underpowered. This is not a cardiovascular safety trial. A little time on the cardiovascular trial in the testosterone trials. These are individuals, 160-something or 140-something individuals that had a moderately high or mildly high risk of heart disease, coronary artery calcium scores of 32 to 38. You guys probably know more about this than I do. But suffice it to say, when you looked at the primary outcome, which was non-calcified coronary plaque volume by CT angiography, you see that the testosterone group increased plaque volume to a greater extent, significantly, versus placebo. But I'll also highlighted here, though, is the fact that at baseline, there was quite a bit of difference in non-calcified plaque volume. So in fact, we still, even though this was adjusted for the baseline plaque volume and was still significant, I'm sort of thinking that maybe this is, still in question as to whether or not this is really the case. And more importantly, I actually don't know, and maybe you all know, what the meaning of this is in terms of predicting coronary risk in the future. Matt Budoff, who's the lead author on this and the investigator that worked with us, would suggest that it's not known exactly what the meaning of this particular finding is. But the secondary outcomes, total plaque volume also increased more in the testosterone group versus the placebo group, but coronary calcium score, in fact, did not. In fact, if anything, went the opposite direction compared to placebo. So what the testosterone trials do not tell us is what the risk of coronary events are. It's totally underpowered to do that. And so the FDA, after the warning came out that maybe it could increase risk, largely based on epidemiology, but also the TOM trial, mandated to some extent, or did mandate, that the testosterone manufacturers come together and do a cardiovascular outcomes safety trial. And so we have the genesis of the TRAVERSE study, which is starting up now, effectively right now, which is a randomized double-blind placebo-controlled study, multi-center study, testosterone gel for 6 years in individuals, 6,000 individuals, 45 to 80, not just the older age group, that have pre-existing cardiovascular disease, some previous event, prevalent disease, or they have greater than or equal to 3 cardiovascular risk factors, obesity, diabetes, family history, a variety of risk factors that you're all familiar with. So at a higher risk group. And the primary outcome here is really non-fatal MI, stroke, or cardiovascular death, MACE, major adverse cardiovascular events. As a sidebar, the secondary outcomes are going to be pretty interesting as well, but we won't talk about those. The prostate cancer guys were particularly interested in this one, but again, we'll leave that for another audience or another time. So how do I consider where we are? What's the current state of our testosterone treatment in men with cardiovascular disease? Well, I think it's clear we have inadequate evidence of risk. There's conflicting observational data as well as conflicting and underpowered testosterone treatment trials. The FDA has taken the tact of being more cautious and saying we should be wary of increased cardiovascular as well as VTE risk, or venous thromboembolic risk, which we won't talk about today. But the European equivalent of the FDA, in fact, looked at the same data and decided, well, there's really insufficient evidence. There's no need for a warning at this point in time. The Endocrine Society guidelines that I participated in also thought there was insufficient evidence, but they thought there were 3 things that we should be aware of. Is that in individuals with class 3 or class 4 congestive heart failure, and excuse me if I'm using the wrong classes these days, but I'm in the old school, so whatever, bad heart failure, okay, there's a fluid retention component to giving testosterone. When muscle increases, fluid increases. So generally those go together. So you should be cautious with bad heart failure. I think only common sense would dictate that you should be cautious in somebody that had an event 3 or 6 months ago. Okay, so that's when more recurrence might occur. And then finally, there's some evidence that thrombophilic states and people with hereditary thrombophilia will have increase in VTEs. So everything that you should, that I've just said, you should take with a grain of salt, really a very large grain of salt, because we have no evidence for any of this. And I will just blatantly admit that this is expert opinion at this point based on what limited data that we have. So when we're faced with a patient, I really like to kind of have almost an informed consent discussion with individuals with heart disease or cardiovascular disease that's about to take testosterone for hypogonadism. and really emphasize the fact there's no clear evidence for risk, but it's still possible, that we need to monitor their risk factors and treat them like I would normally in an individual that wasn't being treated with testosterone. There's no long-term benefits or risk that we know about at this point in time. And if there's no improvement, that's the other thing. If there's no improvement in the way the individual feels or why we're treating with testosterone, there's no reason to continue, and that testosterone should be stopped. And that the key elements of monitoring, at least for this audience, related to this audience, are erythrocytosis, sleep apnea, which can be induced by testosterone, or fluid retention, particularly a problem in heart failure patients. The kind of monitoring that I do, or the formulation that I use, is usually a short-acting. There's now a formulation where you can give them an injection that lasts for 3 months. I'd rather give something that lasts for a couple of weeks, or 2 or 3 weeks instead, or a transdermal that lasts for a few days. Again, really try to monitor for efficacy. If people don't feel any different on testosterone compared to when they weren't on testosterone, then you have to ask yourself, is there a reason to continue this? And then finally, safety monitoring should be with hematocrit, monitoring for symptoms of daytime somnolence and apnea, witnessed apnea for sleep apnea. And if somebody does have a cardiovascular event, which you all see probably in the unit, there's no problem in stopping testosterone for 3 to 6 months. It's not like it's a life-saving medication that we're talking about. And I think it's reasonable to stop for 3 to 6 months and reassess after that period of time whether they need it. Some people, by the way, do need testosterone. Individuals that have castrate levels of testosterone that are highly symptomatic will need it. And they have to be kind of counseled as to what the potential benefits and risks are. And I think most people would want to go back on it after an event. But again, waiting for 3 to 6 months is not a problem, at least from my standpoint. It is for some other people's standpoint, but it isn't from mine. So overall, the take-home messages here, I think, are that the candidate, as we were going to talk about as an objective, should be somebody with unequivocal hypogonadism, symptom signs of androgen deficiency, repeatedly and consistently low testosterone levels. There's no other causes of the symptoms that they have. There's no other causes of low testosterone levels. Should be individuals that have potentially been treated already or being treated for functional causes of low testosterone or hypogonadism. And that may even be treated for their symptoms and signs of hypogonadism with other approaches like PDE5 inhibitors for erectile dysfunction. The risk of cardiovascular events with testosterone treatment is unknown. I'm sorry to say that. I don't have definitive conclusions here. I think we'll have some indication of it when the Traverse trial is concluded. That'll be well after my reproductive life. It's well after my investigative life. But at any rate, that it will be coming. I think the Endocrine Society warnings, I think, are reasonable since I actually participated in those recommendations. I think they're reasonable. Finally, in terms of how to treat and how to monitor, I think it's important to obviously do an informed consent. I put that in quotes because it's not, I don't, as opposed to people that are prostate cancer survivors where I do actually formally have an informed consent template. I think a discussion of benefits, risks, unknowns, I think is reasonable at this point for testosterone treatment in men with heart disease. Using a short-acting form, monitoring for efficacy as well as for safety. If there's no efficacy, stop. If there's a cardiovascular event, hold. And so with that, I'll conclude and take any questions if you have any. Thanks. Yeah.
Can you clarify the Traverse study again for me? So these, I'm assuming we'll probably get the results in 10 or 12 years,
yeah,
given the enrollment rate of the previous trial. But it was males at high risk, presumably either for secondary prevention or
secondary, yeah.
Yeah.
Or at high risk with 3 risk factors. It's the VA population, by the way. Okay.
But they have incidental low T levels. It's not that they're presenting.
No, they have symptoms and signs, and they have low T level on consistently, but not 2 necessarily.
So my question is, if someone presents and they have symptoms and signs and they have low T levels, what do you think the likelihood is of clinicians being willing to withhold testosterone treatment, given how sort of
I think it'll be hard. Honestly, I think it'll be difficult because they can go elsewhere. It's a 6-year placebo-controlled trial. Okay, so is somebody with a low T going to really take a 50 or a chance that they may be on placebo for 6 years? I think that's the challenge of that particular trial, is that I think we have testosterone clinics, we have individual practitioners that are really focused on one T level, low, got to treat the level, or focused on symptoms. And, so I think you're absolutely right. You allude to the fact that this is going to be an exceedingly difficult trial to enroll. I think the fact that they've eliminated having at least two T levels that are low will be helpful. But I don't think that's the problem. The problem is going to be, keeping somebody on the study or even enrolled in the study when there's availability of testosterone. And the payers, particularly, of testosterone will pay for a single testosterone level that's low with a crappy assay, excuse me, this is being recorded, okay, with a not optimal assay, and so I think it will be very challenging. And I guess I'm glad to be on the steering committee and not being actively. We'll be a site, but it's going to be difficult. I think it's going to be a very difficult study to accomplish. And the question is more relevant: is it really needed? I think it's probably good that we have this. Again, 20 years ago, this is what we proposed in a VA cooperative study with Glenn Cunningham and I did. And at that time, they felt there wasn't enough information on testosterone. But in retrospect, what happened was this testosterone generation came on board, and we started having more prescriptions and started having easy to prescribe medications to treat testosterone deficiency. So, water under the bridge. Yes.
Interesting. I'm glad that they're going to do this study. I think it's going to be very difficult, as you've already stated, because of so many confounding things. One of the things in cardiovascular disease is to study the people at highest risk.
Right.
Because they're the most likely to have an event. So
right.
If you want to see testosterone aggravating the situation, you would think that you would want to select the patients that you're going to study at the higher end, people with the highest cholesterol and so on.
Yeah.
And the highest risk. So that's why we're talking.
Yeah, no, I think that's true. It's also likely that those individuals might actually present earlier than 6 years, and so the actual enrollment may be, the actual length of the trial might be less. But I don't know whether, again, the DSMB will actually stop it if there's either a benefit, too much benefit, or too much risk. It's very difficult to know exactly what DSMBs will do. I think the TOM trial was prematurely stopped, but I think it was stopped for good reasons. I think if you look at the kinds of events that happened, as well as the dosage of testosterone, which I think was much too high. And if you actually look at individual testosterone levels in that study, they're well above normal in some of those individuals. And so I think we have to be careful with that. I didn't talk about anabolic steroid abuse by athletes, but the athletes that we've seen that are abusing testosterone as well as everything else under the sun have levels that are 4 or 5 times normal. So that's a population that you might think might be even more risk. But again, I don't know that. There's not enough studies in that area. Anything else? Oh, up there.
Last question.
Another population we see is the transgender population.
Yeah, I didn't talk about that as well.
So any special considerations for
You know, it should be, there should, the transgender population, I'm talking about trans males or trans men, female to male transgender treatment is with testosterone. I think what you'd like to keep in mind is that these are individuals that you're not trying to masculinize in 1 month. Okay, this is something, and so treating individuals with a replacement, a low replacement dose, initially a relatively low replacement dose, and gradually increasing the dose to more replacement-like type levels for hypogonadal men makes the most sense for me. Puberty didn't occur, you know, in one month. So, you know, you have to kind of gradually increase it. Unfortunately, patients are very impatient about masculinizing if you see these individuals, and so there may be a little more rapid, you know, rapid increase in the dose. But that's what I generally would recommend. The reality is that most people get placed on relatively high doses of testosterone that generate levels that are exceedingly high. And the question that's unanswered are genetic females that have higher androgen levels at greater cardiovascular risk than individuals, genetic females that don't have high androgen levels. And so we have some data from PCOS patients or hyperandrogenic states, congenital adrenal hyperplasia, those types of conditions where the levels of androgens are a little on the higher side, suggesting maybe there is a higher risk. But when we're talking about pharmacologically treating women with very high doses, I don't think we have enough information, but there are some meta-analyses that suggest that at least the small numbers of studies that have been performed would tell you that you need to keep the levels in the more replacement level or dosage rather than supraphysiologic dosages.
Great. Let's give Dr. Matsumoto a